Hello, my name is Alexis Foster and I'm a researcher at the University of Sheffield. Today I'm going to talk to you about an evaluation we conducted of a specialist housing advice service for hospital inpatients. As many of you know, hospitals are under immense pressure at the moment, and this is partly because people are facing a delayed discharge. So this is when they're medically fit to go home, but other things in their life aren't organised to make it safe for them to go home. So this is primarily due to their housing issues not being sorted. And there's almost 100,000 bed days lost per year of people having a delayed discharge. So there's different reasons why people might not be able to be discharged because of housing issues. Sometimes it can be because they're waiting adaptations to their home, such as if someone's had a stroke. Or it might be that, for example, that they've had mental health issues and the accommodation that they were previously in is no longer suitable because they've got issues with where they're living. Or there might be someone might have financial problems, which is meaning that they're no longer managing to maintain their tenancy. There's a multi-faculty impact of people having a delayed discharge. First of all, it's worse for the individuals. They have detrimental health outcomes because of it. It's not great for the staff because they're having to spend time trying to sort out people's housing issues, which actually isn't their area of expertise. And it also causes problems in the system because you're having beds occupied, and as we know, people can't get beds. Given this, there's a real kind of need, both from the hospitals themselves, but also commissioners, to actually identify potential interventions to address this issue. Given this, a couple of NHS organisations in Yorkshire worked with a housing association provider to develop and implement a new housing support service. This involved a housing coordinator being based within both a mental health hospital in the area and a district general hospital. How it worked was if an inpatient had housing issues, which might be flagged up as part of a kind of an assessment process or just through talking to the patient, the hospital staff would refer them to the housing support coordinator. The housing support coordinator would then provide people with tailored support, and this was very much adapted to meet people's individual needs. And it could include things like attending discharge planning meetings, applying for housing support for people, helping them to bid for like new social housing properties, chasing up adaptations, so a real variety of support. They also had a role in kind of referring people to additional services. So for example, if people were struggling with debt, which meant they were struggling to pay their rent, then the housing support coordinator would refer them to, say, such a debt advice service. And this would help to address their different housing issues. Because it was a new service, the commissioners and the people involved in delivering the service were really keen to evaluate its impact. They approached us at the University of Sheffield to develop and undertake an evaluation. And we utilised mixed methods because what we wanted to understand was the impact of the service, both on outcomes, but also about things which worked well and didn't work well with the service, so that they could improve its implementation over time. We used a range of methods. We firstly utilised a questionnaire. So this was both for people who'd been through the service, but also we tried to do a start and follow-up questionnaire for people coming into the service. As so many evaluations have been affected by the last couple of years, we had pauses in our study, which meant that we actually had a lower completion of questionnaires than we hoped. We had 37 responses. We also undertook routine data analysis, and we did that of the 488 people which accessed the service. And we were really fortunate because the Housing Association had kept kind of data on their data management system, so we were able to analyse that. We conducted interviews with service users as well as housing and hospital staff. And we also had funding to undertake a sort of exploratory economic analysis to kind of explore whether the intervention did help to kind of reduce bed days and save costs. And as you must do with mixed methods evaluations, we integrated the different work packages. So, as you can imagine, we had a real variety of findings. Firstly, we wanted to explore actually who and why were people accessing the service. Now, really interestingly, we found that 2/3 of service users were male. And when we talked to the hospital staff, they felt that was kind of quite reflective of kind of the populations coming through. As one would expect, there were kind of quite different age profiles and issues facing the people who accessed the service through the mental health hospital and those who were in the acute district general hospital. So, for example, in the acute services, the population was generally older, and there were things like they were having to go to ground floor living, so the housing support coordinator was having to find them new properties because of that, or ranging adaptations. Or for some people, they wanted to sort of move near a family, and she arranged sort of moving out of area. In the mental health service, people tended to be younger and had more sort of complex issues such as substance abuse or kind of history of violence because of their mental illness, which meant they can return to previous accommodation and kind of quite high levels of homelessness. And when we talked to the housing support coordinators, we identified that actually needed quite different skills to do the role. So it was better to have dedicated workforce to each hospital rather than having a general team who could just take on whichever cases came through. As you can imagine, people didn't just have housing issues, they had a number of kind of complex issues, and some of the issues were kind of long-standing. 488 people accessed the service over 18 months, and we had 2 housing coordinators working on the project. Interestingly, as can be seen through this graph, the referral rates were really not consistent at all. It very much depended who was coming into the hospital, and this made planning the service quite difficult, especially in terms of caseloads, because people needed different levels of support over time. So if you were a commissioner planning this service, it might be quite difficult to kind of resource it and plan your sort of caseloads, especially as the other thing was needed the housing support coordinators to be able to see people quite quickly because they could be in the process of being discharged and needed their housing issues sorted. So you couldn't have a service where you're operating waiting lists. So in terms of the nature of support provided, it was generally quite short. The majority of people were supported for less than a month, and less than 10% of people were supported for over 6 months. As I sort of discussed when we introduced it, there was a real range of support people were given, but those kind of skills of the housing support coordinators to adapt and kind of respond to people's individual needs was seen as a real strength of the service. And especially the healthcare professionals valued that because they didn't understandably have that kind of level of housing knowledge. I briefly touched upon how the housing support coordinators would refer people to additional support, and actually over 3/4 of people were referred to other agencies and other services within the housing provider. The housing support coordinators that we had were very skilled and very knowledgeable. They'd been working as housing support officers for a while and had really good connections with other services and really intricate housing knowledge, and that was seen as kind of, again, affecting commissioning. You needed to fund the service at a level which would attract that more experienced housing support coordinator rather than an entry level. As is often the case with these sort of interventions, there was a wide range of impact from it. The service users really valued knowing that there was one individual who was taking responsibility for the housing issues. They weren't having to ask each nurse coming around, well, what's happening? Has anything happened? And things. They trusted that someone was taking care of it. and it was especially useful for more complex cases. There was some early indication that we might be able to reduce hospital stays through having this support in place. But there's also really added value for the hospital staff. They really valued knowing that they weren't having to try and sort out these housing issues, which wasn't their kind of area of speciality, and that actually improved relationships between the ward staff because they knew someone else was taking responsibility and it wasn't just falling on the same person and things like that. There was also an improved knowledge amongst the hospital staff. Having this housing support coordinator spending time with them, they learnt. So there are a number of mechanisms of success which we've been touching upon as we've been presenting. Having that dedicated resource who was experienced, could offer a personalised care and really skilled was important. It seemed to be really valuable that the person was actually embedded within a social housing provider because they could kind of quickly help them access other services within the provider. They knew about the tenancies and things like that. And we found it was really important that the housing support coordinator was fully integrated within the discharge planning teams. So they did have access to patient records, that they were invited to multidisciplinary team meetings. And I thought that was a really useful learning for if you're developing these sort of interventions going forward, it's actually making sure that the kind of non-hospital staff are fully integrated within a clinical hospital team. As always, there were a lot of challenges experienced. So because some of the people coming through the acute hospital would be in for kind of quite short stays, 2-3 days at a time, the housing support coordinators had very limited time to be able to work with them. Whereas actually in the mental health hospital, people generally had longer and they could get in place more support before discharge. The service could only do so much. A lot of the constraints people were experiencing were because of the lack of kind of external housing stock. There was a lack of follow-on mental health supported housing. So the housing support coordinators can only work within the system. Some people actually require kind of follow-up support. So once they were discharged from hospital, the housing support coordinator service finished. But 2-3 months down the line, some of their housing issues might materialise again and they didn't have anyone who could help them. So they felt like there was a need to be able to kind of both continue some support post-discharge, but also have a service like this embedded within some of the community teams, such like the community mental health teams. And there was also a high number of people experience homelessness, which is again a reflection of what's going on more widely. So just to summarise, the housing support coordinator service was really valued by both service users and clinical staff. It's potentially a very valuable service to roll out to other hospitals, but also within community services. And what we found was that relatively it was fairly low cost, but really highly valued, which makes it more feasible to roll out further. You need to think about where it's to be placed within hospital teams and make sure that you're funding highly skilled practitioners who know the system, but also have links to follow-up services. Thank you ever so much for listening, and I look forward to receiving questions at the conference.